that's working. To those of you just joining, we're just going to hold on for a sec until everyone's in. We'll give it a couple more minutes. We've got 50 people in so far. That's 8 o'clock, so in the interest of keeping to time, I think I'll just get started. So good evening, everyone. Thank you for joining us for our first BOTA Sunday supper session. For those of you that don't know me, I'm George. I'm the current BOTA Vice President, and we're going to be doing these sessions once a month over the next year to cover some high-yield FRCS topics. So this month, we've got some excellent speakers who are going to chat to you about hands. We've also got a couple of the BOTA committee members on the panel who'll be fielding your questions at the end of each session. So if you do have any, please make sure you use the Q&A box and we'll answer as many as we can. Hopefully you find these sessions useful in your revision. So first up, we've got Mr. Wee Lam. He's a plastics and hand surgeon based in Edinburgh and past president of the British Foundation for International Reconstructive Surgery and Training. And he's going to talk to you about the congenital thumb. And for his talk, we've got a pre-recorded talk. So hopefully you can all see.
Good evening. I want to thank BOTA for inviting me to come and talk about congenital thumb anomalies. I will broadly divide my talk into why they occur and how we manage them.
Right,
hi guys, yeah, I think we received the message about the audio. I think George is just trying to sort that out.
I have no. All right.
Good evening. I want to thank BOTA for inviting me to come and talk about congenital thumb.
Is there audio there now?
I will broadly divide my talk into why they occur and how we manage them. So why they occur, or embryology, which you may need to know a little for your exams, and I'll try to make it as interesting as I can for you. Upper limb development begins on day 26, when the embryo is just the size of a small seed. And a good place to start in embryology is the timeline, which is 4 to 8 weeks of gestation, and from 8 weeks onwards, the hand develops to its full size. For the exam, you can mention that limb formation is a lateral outgrowth of the limb bud from the embryo, which is essentially growth of the mesoderm into the overlying ectoderm. And where it comes out on the embryo is under very tight control through the HOX and TBOX genes, which are transcription factors. The upper limb then grows as programmed in 3 directions, each controlled by a signaling center and the main responsible protein pathway. So the proximal distal axis, which distalizes, controlled by the apical ectodermal ridge and primarily FGF. The zone of polarizing activity, which ulnarizes, ulnar to radial direction through the Sony Hedgehog protein pathway. And then it is hard to visualize, but there is a dorsal-ventral axis controlled by something called the WNT pathway. This is one of the most useful diagrams I found to help me understand the molecular pathway of limb development. The secreting cell in the signaling center, for example, the AER, secretes the ligand, the FGF, and then it binds to a receptor, which activates a transcription factor, HOX or T-box, for example. So it is very hierarchical and organized, and if at any point something goes wrong, then this will result in a limb anomaly. Another thing I found useful is this animation which we developed, the AER and the ZPA, and then the dorsal ectoderm on the other side. And there is constant interaction between the three axes to make the limb grow appropriately. Now, how do we know all these things? Most of our knowledge comes from animal experiments using the silky chicken. And so people have removed the AER, for example, and produced a truncated limb similar to the transverse arrest in humans. Replicating the ZPA leads to a mirror hand, and defects in the dorsal ventral axis leads to this rare condition of anonychia, where the palmar tissues appear where the nail is. So this is a summary slide, and what I say to trainees, BOTA or PLASTA, is that this is all you need to know for the exam. And hopefully by now, as you look at this table, things will make much more sense for you, and this is probably all you need to know. But since we are looking at thumb anomalies, let's go a little bit deeper into why they occur. And thumb anomalies can be either too many, too small, or missing. So we have seen how the zone of polarizing activity controls ulnarization. And recently, Oberg and others have shown that there is a diffusion gradient of Sony Hedgehog from the ZPA, which influences digit formation. And when it reaches the radial side, there is actually very little Sony Hedgehog. It just stops short of this radial border, and the thumb doesn't get any Sony Hedgehog at all. So in polydactyly, it may be that the Sony Hedgehog influence, instead of stopping short of the radial border, extends. And now we can see perhaps there was just a little bit too much Sony Hedgehog and the formation of an extra digit, allowing the formation of an extra digit. But because of the space constraint, it was never quite enough to make two fully formed thumbs, which may explain why it is usually, this is what I tell parents, it's usually more of a split thumb rather than an extra thumb. And because it's an ulnarization pattern, why the majority of thumb polydactyly has a bigger ulnar duplicate. And this is important, and a smaller radial duplicate, because the ulnar duplicate is formed first. This is the majority of the pattern. This is a gift for hand surgeons because you don't have to reconstruct the ulnar collateral ligament. You just remove the radial duplicate. This is from our lab in Edinburgh. We work with chicken embryos, and then we look at the chicken limbs. One of the things we do is to add atopic Sony Hedgehog to the anterior limb bud. And what we do, what we found was that when we do this, we actually produce radial polydactyly. And we found that the more Sony Hedgehog we put, the more severe the radial polydactyly. And we found that if we increase the dose of atomic Sony Hedgehog, so you add a little bit, you get a radial polydactyly. You add even more, it actually suppresses radial structural growth, when this led to radial dysplasia and also thumb hypoplasia. And so from our experiments, we can actually come up with a theory about thumb hypoplasia being a radial longitudinal spectrum, which we have known all along. So this is a Blau-5 thumb, and the radius, I don't know whether you notice, is just a little bit shorter than the ulnar. This is a Blau-2 thumb. Initially not apparent that a forearm is shorter, but inevitably you will find that it is always shorter than the contralateral forearm as the child grows older. And so from here we can come up with a spectrum based on the dose of atopic Sony Hedgehog, and this could explain how the majority of thumb anomalies happen. Now, enough of embryology, let's move on to how we treat these thumb anomalies. So I want to look quickly at thumb index syndactyly to really highlight the importance, first of all, to really highlight the importance of the thumb. We always try and free the thumb as the first priority. So when you get a hand like this, the first thing you need to think is, how do I free the thumb? You don't need to know how to draw the flap, but it is good to know the surgical priority. This is another case. Again, what am I going to do here? Free the thumb. This is a rosebud hand in Apert syndrome. Again, what do I do here? Thumb is the priority. This is a cleft hand. What do I do here? Again, thumb is the priority. Get the thumb out because it is a priority. Now we're going to move on now to thumb duplication. When you look at thumb duplication, Warszawa classification is the one that you need to know. And when you describe it, you can say that it is a skeletal replication or skeletal duplication, but sometimes it is difficult to know when there is cartilaginous connection. The usefulness of Warszawa is for communication. I think there's very limited use for surgery because not all Warszawa 4 are the same. I'll explain that later. Even numbers are complete duplicates, and odd numbers share a common base. Now, why do we need to treat thumb duplication? I always tell my registrars that when approaching the congenital hand, and this is to make things interesting really, think, what are your surgical goals? Why are you doing this? And what are the surgical challenges or surgical pitfalls? Now, when I treat a thumb duplication, the surgical goal is to produce one straight, stable, strong, and mobile thumb. The most important thing, the most difficult thing for me is to get that straight thumb. And the cosmesis is very important. To get it right is quite difficult. So the surgical challenges are because deviation is common, the anatomy is often abnormal, the structures are unpredictable, and I think it's very difficult to achieve a normal looking thumb because it's not gonna look the same as the other thumb, whatever you do. So these are my go-to principles when I treat a thumb duplication. There are principles. It's not just chopping out a thumb. The first is incision, and these are my early cases where I learned the lesson of not encroaching onto the glabrous, non-glabrous border. So this is another case where I did that. I'm a lot more respectful of this border now. I will stick to the glabrous, non-glabrous border so that the final results will look better. So this is what I do now, whatever the initial configuration. The second principle is to reconstruct and free all ligaments and tendons. So the FPL, which I usually cut, and the EPL, which I usually detach and suture to the remnant thumb. Importantly, and you must mention this in your exam, the radial collateral ligament, you must find it and free it and reattach it for stability. It always inserts into the radial duplicate that you are removing. Now, the next principle is to perform an immediate osteotomy if necessary. So if you're gonna do an osteotomy, do it at the time of the first operation. And there are times when I didn't, I have regretted, and it's very difficult to correct a deviated thumb subsequently. Now you may understand this when you see this Warszawa 4 configuration. This is the divergent convergent thumb. You have to perform a double level osteotomy. If you don't, the thumb won't be straight. And so for this case, we did a closing wedge here at the neck of the metacarpal, and then another closing wedge at the neck of the proximal phalanx to get that straight thumb. At this age, you can still get away with putting sutures. There you go. This is a Warszawa 2 thumb, and what I did here was to was a closing wedge osteotomy to get it straight. Generally, you can get quite good results when it's not too complex. Sometimes you get a configuration like this, and in this case, I took the radial remnant and I inserted it as an opening wedge osteotomy, and this is really the best I could get. It's not perfect, and sometimes it is very difficult. And the last principle is skin closure. And this is quite important. This is the bit where my registrars may say to me, do you want me to describe and write the notes for you? And I tell them, no, you stay and pay attention to this very important part of the operation. So let's look at this wasal to duplicate thumb, respecting the glabrous, non-glabrous border, removing the radial duplicate, screening it to make sure that it is straight, and deciding whether you need to perform any immediate osteotomy, and then closing it, respecting the border. And this closure is something that you have to do so very carefully to make sure that it really produce a normal looking thumb. This is a wasal 4 duplicate. Again, respecting the glabrous, non-glabrous border. Identifying the EPL, freeing all ligaments and tendons. Looking at the bony configuration. Here I perform a laser osteotomy just to shave off the head of the metacarpal, reconstructing the radial collateral ligament together with the APB. And this is the skin. So what I do now is that I always suture the skin from distal to proximal, always distal to proximal. And I always suture it as it is. And I look at it and I know this is too bulky. Then I mark it out again, and then I excise the skin. And then finally, this is what I get at the end. Just so paying attention to skin closure. This is so important. So there's a lot of pitfalls that can go into this, there are in this operation. Let's move on finally to thumb hypoplasia and thumb aplasia. So thumb hypoplasia, the classification that you need to know is the Blouw classification. So this is the way I remember or understand the Blouw classification. I think of the thumb and I think of the thinner muscles. So in Blouw 1, what you have is a slightly smaller thumb. It's very difficult to diagnose this. Often these children are not diagnosed, and I think it's fine. The first thing to read in Blouw 2, the first thing to really go are the thinner muscles. So there's thinner hypoplasia, and as a result of that, the thumb finds it hard to abduct. And because of that, you have a narrow web space. And because of that, the thumb keeps trying to abduct, and this leads to a lax ulnar collateral ligament. So there is a sequence to things. So this is a Blouw 2. So the focus of Blouw 2 is on the MCP joint. Now in the Blouw 3, all of the above, but much more severe, there is much more severe thinner hypoplasia. And there is still a metacarpal, but it is hypoplastic, and the CMC joint is therefore present. This is a 3A. And so this is a Blouw 3. Blouw 3 is divided into 3. And this is a Blouw 3. It is all of the above, but much more severe. So there is thinner hypoplasia, but much more severe. And Blouw 3 is divided into 3A and 3B, where in 3A there is still a metacarpal present and therefore a CMC joint, although it's hypoplastic. And 3B is where the metacarpal is missing proximally, and therefore there is no there's no CMC joint. But everything is a lot more hypoplastic. And then finally, 4 is a floating thumb, and then 5 is an absent thumb. So this is the Blouw classification, 1 to 5. 3 is divided into 3A and 3B. And the significance is that 1 to 3A, you will focus on reconstruction. 3B to 5, you will probably recommend a politicization. So let's come back to this template again of what you're trying to do in thumb hypoplasia. What are your surgical goals? What are you trying to create in thumb hypoplasia? And what are the surgical challenges and pitfalls? So the surgical goals are to create a stable, mobile, sensate, and opposable thumb. And this can be either through reconstruction or politicization. And the surgical challenges, or they're numerous, there are multiple factors to be considered in the creation of a thumb. So let's look first of all at reconstruction, which is 3A and above. And you know the problem, we talk about this. There's thinner hypoplasia and therefore very weak opposition, maybe. There is a narrow web space, and there is laxity of the ulnar collateral ligament or instability of the ulnar of the MCP joint. So for the first web narrowing, you can mention that you will do a Z+T or the jumping man flap. Again, for the FRCS off exam, I don't think you'll be asked to draw this. For ulnar collateral ligament laxity, for a uniaxial instability, if it's just the ulnar side, you can think about application with a figure of 8 stitch. I usually use a follow PDS. If it is multi-axial, if there is multi-axial instability, you can think about a chondrodesis, or you can use the FDS of the ring finger, especially when you're doing an opposition plasty. I don't think you need to go into too much detail about this. For opponent plasty or opposition plasty, the most popular one is the Huber transfer using the abductor digiti minimi, where you remove it from its insertion. I usually keep the origin intact and then I swing it over, and that becomes your new thinner muscles. So that's you can see here the APB being swung across, and that's the APB there. You can use the FDS of the ring finger as well. That's another method. And if you use that, you can stabilize the MCP joint. So these are the main steps for reconstruction. Now, politicization indications, as mentioned, is for Blau 3B and above. You may use it in a 5-fingered hand, or you will use it in trauma. So sometimes you may be asked to talk about politicization, and it's very confusing to describe politicization. So this is the way I will recommend that you say in the exam. You can just say politicization. It's a procedure I've never seen before, but I know that there are 4 major steps or principles. The first is incision. Secondly is mobilizing the index finger. Thirdly is shortening, rotation, and placement. And lastly, rebalancing. So first of all, incisions, and you definitely don't need to know how to draw this, but the idea is so that you can close the wounds primarily and to create an adequate first web space. Second step is mobilization of the index finger, and you locate the common digital artery as it branches off to the middle finger, as you can see here, and you ligate that, and then you find the vein on the dorsal surface and you isolate that, and then the nerve as well. And then the third step is shortening and rotation. So the buzzwords to mention are that you rotate 150 degrees, you remove the metacarpal of the index finger through the growth plate, you ablate the growth plate, and then you hyperextend the metacarpal head, and you fix that onto the trapezoid. So these are the keywords to mention, and this is the key step in rotating and shortening of the index metacarpal to become a thumb. And finally, rebalancing. So the idea is to take the tendons of the index finger, the EIP and EDC, and convert them to the tendons of the thumb. So the EIP becomes the EPL and the EDC becomes the APL, and then you move the muscles around. And this is the final result, post-op results. It's a bit bruised, but you'll be fine. Now, this is one case which I thought would be quite nice to show what I did subsequently. Opposition wasn't great, so I carry out an FDS opponent plasty or opposition plasty. So that's the FDS tendon. And then I use an FCU loop and suture that. And you can see here, you can use that to stabilize the MCP joint as well. And you can give the child excellent opposition and also extension. So congenital thumb anomalies, why they occur and how we manage them. I hope this has given you a better idea of what they are and how to answer questions in the exams. Thank you very much.
Thank you very much. Thanks, Wee. That was a really brilliant and insightful talk. Thank you. Great pictures. And I'm sure, as someone mentioned on the chat, they'll be looking over your talk in the weeks to come to really get all the detail as well. We've got a few questions. This sort of debate, as we know, isn't always particularly or able to be covered by orthopaedic trainees. So there's a lot of interest. One of the questions that I'll start with is related, Wee, to timing. So I guess if you're looking at both the duplicate thumbs and the hypoplastic thumb cohorts, what are your thoughts on timing or optimal timing for surgery, and are there limits to the timing, basically?
So I think for the exam, you can say that the majority of congenital hand surgeries should be performed at around the age of 1, because it is considered the safe anesthetic age. And these are non-urgent cases. So 1 should be the age for thumb duplication, thumb hypoplasia reconstruction. You can probably delay a politicization to about slightly later, 1.5. But that's sort of the general age for congenital hand surgery.
Yeah, fantastic. And so just looking for the thumb duplication, and I know from when I was revising FRCF Orth, there were quite a few references for duplication to the, how do I pronounce it, Billow-Cloquet procedure. Is this performed, and do you perform it? And if so, when would you perform it, I guess?
So for those of you who are not familiar, the Billow-Cloquet procedure is to take half of each duplicate thumb and then to join them together to make one thumb. And the only time you should consider that is when the both duplicates are really tiny, and that if you just excise one of the duplicate, the remnant duplicate looks really small. So that's when you consider whether you should take half of the other and half of each and try to make it into one. It is something that is not performed very often now, because you end up with a very unsightly ridge on the nail. So lots of people don't do that anymore.
Yeah. Thank you, Wee. And just for the purposes of time, one last question. For thumb hypoplasia, one of our viewers asks, could you also supplement politicization, or rather than politicization, perform a toe to hand transfer, so a free toe transfer? What are your thoughts on that?
So that's a very very big question. If you have a Blau 5 total thumb aplasia, no thumb at all, then a toe to thumb is quite a difficult thing to do, because you've got no tendons in the hand that you can join the toe to. So it's just going to be a toe that doesn't move. If you have a 3B or 4 or whatever, then you can take a toe metatarsal and just reconstruct the CMC joint. That's a very short answer to a very big question.
Yeah, that's great. Thank you very much, Wee. Wonderful video, and great to answer those. I'll hand over to George. Thanks, George.
Great, thank you, Matt. So next up, we've got Mr. Andy Logan. So he's a hand surgeon based in Cardiff, previous chair and current chief examiner for the British Hand Diploma course, and he's going to be talking about tendon injuries.
Okay, you should have my screen now, guys. I hope you can all see it. Can you give me a thumbs up? Yeah, good. Thanks, Alison. Okay, so so tendon injuries, it's quite a large topic. So the way I'm going to run it here is I pick stuff that I would be asking you if I was examining you on extensor tendons and flexor tendons if it came up in the exam. So what I'm going to do is I'm going to ask you questions, show you cases, and then pause in between to give you a chance to answer to yourselves. So we're starting off with extensor tendon injuries. Now, these are open injuries, so a cut or laceration. And I'd probably ask you about the extensor tendon injury zones. Now, in clinical practice, I tend not to use them as much, but they are useful to know, and I tend to describe the anatomy. But this question would lead on to, for higher order thinking, gaining more marks, to look at the anatomy in the different areas of the zones and how that's related clinically. So, for example, I'd want you to know about what the extensor tendons are like in, say, zone 5 and zone 6, where they're more rounded. You're looking at zone 4, where you've got the problems of a flatter tendon, which is more difficult to repair. You then have the zone 3, where it could detach from the dorsal base of the middle phalanx. And then you've got the problems with zone 1 and zone 2 as being a thin, flat tendon. So What I want you to know is the difficulties of each area and how you would go about repairing them or treating them in that area, because it is things you probably would have done on call as a junior before the exam. Moving on from that, I would then escalate this up to the zones of injury in the thumb. So T1, 2, and 3. If you knew a little bit about the differences, say, for example, T1 and T2 areas, the tendon, although it's flat, it is a little bit thicker and easier to suture. Zone T3, it's looking a little bit more like a normal tendon, as it does a little bit in T2 as well. But what I'd ask you is what would you have to be careful with extensor tendon injuries, with the extensor pollicis longus in proximal zone T3 or zone T4. Okay. The answer to that would be, if you get a cut around here at zone T4, then the extensor tendon can retract. So I'd ask you where it can retract to, and it can retract all the way down to Lister's tubercle here, and that's normally where you find it. So if you're in a clinical situation and you have a tendon laceration there, you have to be wary where to look for the tendon. I'd also ask you how you test for the integrity of extensor pollicis longus and how you can test to see whether it's retracted. Okay, so think about that. I'd get you to put your hand on the table and extend the thumb, or retropulse the thumb, which is the standard test for EPL. And if you can see the tendon rise up, then it hasn't retracted. If you can't see the tendon, it may be that it hasn't retracted and they're just sore and can't do it, or it could have retracted. So when you come to do your operation, you're a little bit more wary. This is a clinical case moving on to someone with a closed extensor tendon injury. Now, they both got the same injury. The one on the left is a carpet fitter that was pushing the carpet towards the skirting boards and stubbed their finger. And the one on the right was just pulling down their socks. Now, sometimes they feel some pain, but usually they notice something that they can't extend their finger when they then look at it. So what is the diagnosis here? Okay, I can all imagine you saying, this is an extensor tendon rupture from the distal phalanx. What's the eponymous name for this? Yeah, mallet finger. Okay, so what investigations would you get for this patient? What investigations? Well, I wouldn't get an ultrasound scan, you don't need to. I would get an X-ray because you want to see whether there's a bony component to it or not. Now, these are the X-rays of this particular person. As you can see, there's no bony injury there. So what is your treatment and why do you treat it that way? You treat it in an extension splint. So effectively, you're extending the distal phalanx. Now, why can you do that? Why don't you have to operate on these and repair the tendon? Because the tendon, the extensor mechanism, doesn't retract very much. And so therefore, if you put the distal phalanx back to where it should be, then the tendon is close enough to heal back on. It doesn't matter what splint you use, as long as you're putting it in extension. And the one on the left is a typical mallet splint. How long do you put it on for? Well, soft tissue mallet, probably 6 to 8 weeks. I'd err more towards the 8-week side. But again, as long as you say one or the other, different units will treat it in different ways. Because what you've got to remember in the exam is the examiner's not going to be examining you on what they do personally themselves. There is a range of opinions sometimes that can differ, and each of those opinions can be correct. So what about someone like this, who's got a bony avulsion on the top there? I treat it the same. I put in a mallet splint. I ignore this fragment. You can ignore it. You don't need to fix it back on. Some units will try and fix it back on or support it with wires. But I think for the exam, the majority of people would just treat this in a mallet splint. What I do watch out for is whether this distal phalanx becomes incongruent once it's extended. So I do get a lateral X-ray in the mallet splint to make sure this bit here remains congruent. Now, if it doesn't remain congruent and it subluxes palmarwards, then I would treat this with a longitudinal K-wire across the joint, but I'd still ignore that fragment. Okay. Open injuries to the distal interphalangeal joint with an extensor tendon laceration, not necessarily with a bony injury, it's usually with a cut. I would treat it in a similar fashion, in the sense that I would wash the wound out, which is the normal procedure under local anaesthetic. And because you've got a wound dorsally, I would keep the distal phalanx in extension with a longitudinal K-wire. If you try and repair the extensor tendon at that level, it's friable, you can't get a stitch in it, it all bunches up. So you're better off just treating it like a closed mallet, but I would use a longitudinal K-wire, so you haven't got a mallet splint over the wound getting all wet and macerated. Okay, we'll move on to our next clinical case. This is a patient who dislocated their proximal interphalangeal joint whilst playing sport. Now, they come to you in accident and emergency, you're called down and they show you their dislocated finger. What key piece of information do you want to gain from visualizing this dislocation? It's the direction. If you have a dorsal dislocation, then the palmar structures are the ones that are going to be injured. Palmar plate, part of the collaterals. If it's a lateral or medial dislocation, radial or ulnar, then you're going to have a collateral gone, part of the palmar plate. If it is a palmar dislocation, the central slip, which attaches to the base of the middle phalanx, would have to have torn in order for the middle phalanx to dislocate. So that gives you a clue as to what you need to treat. So in this particular patient who's developing this deformity, what do you think has happened? So he has got a boutonniere deformity here, or certainly the start of one, from an closed central slip rupture from the dislocation. Now, what special tests would you do for this patient to confirm that diagnosis? I think one of the better tests is Elson's test. Now, you can do this either by holding the proximal interphalangeal joint flexed over the end of a table and resisting active extension. When you do that, in a normal person, that is floppy, the distal phalanx. If you look at the picture on the right here, this finger is the one with the central slip rupture. So if you put your two fingers together and try and extend them against each other, then you can't touch the two fingernails together. Okay. If the central slip has gone, then all the pull is through the lateral bands, which join the conjoint extensor here, and that causes extension of the distal phalanx. Okay, so that's Elson's test. Whoops, I've given you the answer to the next one. So treatment. Now, there are more than one way to treat this, and the examiners will be aware of the different methods of treatment. The commonest treatment for this is extension splinting, moving on to an exercise splint. Now, the reason for that is the outcomes are pretty much the same long term compared with surgical treatment. However, if you did decide to treat these surgically initially, then I'd want a reason for that, and you'd have to justify that. So for example, if it was a sportsman and you didn't want them in a splint for 4 to 6 weeks and then a stiff finger that's more likely to be injured when they go back playing, then you can make an argument for surgery and get them going earlier. Okay, so I'd accept both answers as long as you've got justification for it. Okay, so flexor tendons. Looking at the normal resting attitude of the hand, here you've got the normal cascade going from the slightly bent index finger down to the small finger. You can see the palmar creases. That's the normal looking hand. We've all got a normal looking hand, and it's something we can compare with. Now, this is a patient who was going out for a run and they fell onto their outstretched hand and they got a hyperextension injury to the proximal interphalangeal joint, or that finger. They come to see you with pain in this joint, difficulty moving it, and you take this x-ray. So my question is, what is attached to that bony fragment? Now, if you say flexor digitorum superficialis, you are to face palm yourselves, okay, because it is not, it is the volar plate. And I get flexor digitorum superficialis as an answer too often for this. So it's a volar plate avulsion fracture. Okay, so I just sneak that in just to confuse you a little bit. Now, this is our next case. This is somebody who was cutting a piece of bread, their hand slipped and they cut their palm with a knife. Now, you'd be asked to describe this photograph of a gentleman who's trying to flex his fingers. So you describe that for me, and I'd ask you what structures could be injured. Now, it's all about anatomy. He's most likely cut his flexor digitorum superficialis and profundus, plus there could well be some digital nerve, digital vessel injury as well. Testing for FDP is easy because it's on the distal phalanx and you can just hold the middle phalanx and get them to flex it. My question would be, is how do you test for flexor digitorum superficialis? You do this by holding all the other fingers in extension. And then I'd ask you why you do that. And the reason being is the profundus behaves as if it's attached to a single muscle belly. So if you're holding the other extensor tendons of flexor digitorum profundus extended, then it's going to prevent that muscle from contracting. And therefore, any movement of the finger is going to be superficialis. Then I'd ask you about the treatment. So treatment, I mean, it's fairly obvious, explore the wound and repair the structures. I would then move on to ask you how you did your tendon repair. Now, I don't mind what you say as to how you did your tendon repair, unless you said something completely ridiculous. The technique doesn't really matter as long as you've got to describe technique. Kessler, Locke, Kessler, Savage, there's lots of other different ways. Moving on for higher scoring, I'd want to know what suture you use, why you use that suture. Do you use braided, monofilament, and the advantages and disadvantages of each. Number of strands you use and why. Be safe, use 4 to 6. You can use 2, but the less strands you use, the more chance there is of rupture. The more strands you use, you get a more bulky repair, increased chance of adhesions, more soft tissue handling, etc. So that is scoring you higher order thinking points. Finally, we have our rugby player who was going in for a tackle, grabbed the shirt, and the player got away from him. He didn't really notice it at the time, but after the match, when he was trying to make a fist, this happened. So what has he done? Yeah, he's avulsed his flexor digitorum profundus tendon from the distal phalanx. Now, what investigations would you do for this? I wouldn't do an ultrasound because the diagnosis is obvious from that clinical history. but some may say that. I would get an X-ray because they can have a bony component to it. So in this particular case, you can see the scalloping here where the tendon was originally detached. Okay, so why is the bone from the end of the tendon stuck there? Why is it gone all the way down to there and stopped? The reason being is it's because it's got stuck on one of the pulleys, and it's got stuck on the distal aspect of the A2 pulley. So I would then ask how you treat this, and I'd be happy with simple answers such as you'd want to reattach it back to where it was before. Now, you might be asked as to how that is done or whether you've seen that done. And I don't think that really matters. I would then ask you about what your rehab protocol is afterwards. Now, there are a number of different rehabilitation protocols, and I'd expect you to be at least a little bit familiar with one of them, whether it's a CAM regime, Belfast, Manchester regime. And I'd want you to tell me, for higher order thinking, why you use a certain rehab technique. And by and large, it's to keep the tendon gliding. You're doing active and passive range of movement, and you're also protecting with splints in some of the regimes to prevent hyperextension accidentally, which could cause a tendon rupture. Okay, so in summary, that's a whistle-stop tour of probably the questions that I would pick to ask in the exam for tendon injuries. It's a relatively small topic, and they're questions that you can take to quite a high level to score maximum points with higher order thinking. So my advice would be is start off simple, because most of the cases you're going to have had dealings with during your training, and then your examiner will bring you on to harder and harder questions to score more points. Okay, thank you.
Thank you very much, Mr. Logan. That was an absolute tour de force of exam gold there. I think I've run out of ink from the amount of scribbling I was doing. I think we're running quite close on time, so I think we've probably just got time for the one question. We've got loads of great questions. Some of them are quite detailed. I think we've got some high-level trainees in the audience tuning in, but possibly a bit more of a generalized one. What would you do if you found a partial flexor tendon injury? So say you're examining a wound in theatre and you come across a partial flexor tendon injury. The question is, at what point would you consider repair versus just debridement and closure?
Usually, I would say if it's, I mean, if you look at the reason to repair or not, I mean, you could almost go with 50%. You don't have to put a core suture in. However, if there is a big enough amount of tendon involved that you could put perhaps a 2-strand core in and enough room to fit that in, then I probably would. If there isn't, then I would do, well, not a circumferential suture, but I do an epitendinous suture using 6-0-proline just to tag the edges together so that it doesn't catch when it's gliding. I then look at it gliding. I might do a release of partial release of a pulley, proximal and distal, depending where it wants to go, to stop it snagging.
That's brilliant. Thank you very much. I think, yeah, sorry to everyone else who's asked questions. I think in the interest of time, we'll have to move on to our last speaker.
So last but not least, we've got Mr. Adrian Chojnowski. He's an orthopaedic hand surgeon in Norfolk and Norwich, and also chairman of the AO Hand and Wrist Group, and he's going to talk about the rheumatoid hand.
Okay, thanks very much indeed. Can everyone hear me, and can you see my screen okay?
Yeah,
good. That's great. Thanks very much. Thanks very much for asking me to talk about the rheumatoid hand, and let's just think about some salient features of this. The aims are, of course, pain relief, to improve function, and again, cosmesis does come into it. You've got to bear in mind that the rheumatologists aren't convinced that hand surgery is necessarily the best thing for their patients, and it's great to work in combination with a rheumatologist. And the simple reason for that is a hand can look quite deformed, but it could actually function pretty well. So you want to know specifically what the problem is when that patient presents to you. When you're taking a targeted history, you've got to start outside the hand, and really that means starting at the cervical spine, because of course that rheumatoid patient could have cervical spine disease. They might have nerve root entrapment, or in particular, they might have C1, C2 instability, and that could be a problem in terms of intraoperatively. You'd want to think about any instability with flexion extension views in that case if you were considering a general anesthetic. Of course, you need a good shoulder and a good elbow to place the hand, or at the very least, you want to know if there are any difficulties there. So really a quick assessment of a shoulder and an elbow is important. And of course, these patients now are on very powerful immunosuppressant treatments. Methotrexate, a slightly older drug, is still used as a first line and can be continued through surgery. In a classic trial, quite old now, where methotrexate was discontinued prior to surgery, patients had a far worse outcome. The newer generations of biologic response modifiers, or biologics, anti-tumor necrosis factor drugs, and they're now onto their third generation, may need to be stopped prior to surgery because of a theoretical increased risk of infection. So it's important you do take that drug history and establish what medication the patient's taking. Remember, rheumatoid arthritis is a synovitis. It's inflammation of the synovium, which causes destruction of the capsule, the ligaments, and ultimately a degenerative change occurs in the joint. You're going to see it around the wrist. The wrist may look bulky. You'll see it around the finger flexor tendons, classically on the distal third palmar aspect forearm. You'll see a picture of that just in a second. But of course, any joint can be hot to touch, look swollen. Tendon rupture can occur through the synovitis, or an attrition rupture secondary to joint destruction. And you've got to know a couple of classics. The Vaughan-Jackson lesion, which I'll come to later, is an extensor tendon disruption sequentially from little ring then middle finger caused by a prominent ulnar head, the caput ulni. Manifelt lesion, rupture of the flexor pollicis longus, caused on the volar side where it runs against the scaphotrapezial trapezoid joint, some little bony, nasty osteophytes causing attrition rupture there. In the olden days, synovectomy was often our first surgical procedure, but it's actually quite rare now with biologic agents to see a patient with big wet synovitis. That means you only tend to see the missed cases or the non-responders, tricky ones. So here's a clinical slide showing a big bulging synovial mass around the flexor tendons where you find synovium, and you can also see a carpal tunnel decompression, which I'm sure the patient would have felt a bit better from. So what causes the classic rheumatoid deformity? Well, generally, the exam answer is to say it starts at the wrist. The carpus supinates. It starts to pull away from the ulna because of the destruction of the extrinsics and volar-sided ligaments, extrinsic ligaments. The extensor carpi ulnaris then tends to slip off, exacerbating it, and the carpus begins to fall away from the radial side, translocating to the ulnar side. That's a lot of Latin. Let's have a look at a picky. That's what it looks like. Here you can see a very prominent ulna, caput ulni. But of course, the ulna isn't the problem one here. It's the carpus that's fallen away. The ulna doesn't shift or move. That's fixed firmly to the elbow joint proximally. So it's the carpus falling away from the head of the ulna, which makes it look prominent, the extensor carpi ulnaris tendon slipping off. And this is in a supinatory fashion. Here's a rather destroyed looking wrist, I'm sure you'll agree. And you can see here that the lunates ended up somewhere or other in the dip towards the ulnar head. The radial styloid is quite uncovered. And you'll see examples of the whole carpus beginning to move in an ulnar-sided direction, ulnar translocation of the carpus. That only happens when there's significant destruction of the supportive extrinsic ligaments. So here's a schematic of our classic deformity. It's an ulnar-sided translocation of the carpus. It's radial deviation of the metacarpals, and it gives ulnar drift, as it's called, of the proximal phalanges. And of course, it doesn't take much to imagine that those flexor tendons are now going to end up sitting slightly on the ulnar side of the finger, and that's going to exacerbate that ulnar deformity. The extensor tendons then start to sublux into the valleys, as is often a term used. In other words, they start to sublux onto the ulnar side. This is exacerbated through synovitis and destruction of the supportive sagittal fibers of the extensor hood. And that, of course, will accentuate that ulnar deviation at the metacarpophalangeal joints. This is an example of carpal collapse presenting relatively acutely in a young patient who really developed their inflammatory arthritis resistant to medication over a few years. You can see here that actually there's not so much in the way of a classic osteoarthritic looking change. There's no sclerosis, no cysts, no osteophytes. But what you can clearly see is the lunate staring downwards, pretty much overlying the capitate. In fact, the whole of this proximal carpal row on the AP doesn't really look like it's there. It is there. It's just overlying the distal row. And this is carpal collapse caused through extrinsic ligament destruction. The destruction has been so aggressive, so acute, the carpus has collapsed before the degenerative changes have begun to occur. In this situation, we would look to stabilize that wrist. And here's a classic example of how we tend to do it with a dorsal wrist plate and a fusion. It's worth just thinking in terms of management of the wrist, as there are other options. You'll see fusion plates. You might just see a wrist replacement. The technology is not great. It has aseptic loosening issues. And also have a quick look and see what happened to these ulnar heads. They've been excised, the Darroch's operation. And you can see how the remnant ulnar stump is impinging against the radius. So again, a classic problem of the Darroch's operation. Here's an example of somebody pitching up with their hand, a rheumatoid arthritis sufferer, and it looks pretty deformed, doesn't it? But it's not in the classical way. And you think, well, hang on a minute, you've just told me there's ulnar translocation. Okay, might have that here. But there's not so much of that sort of drift, is there, of the radial or ulnar side? Well, people don't always have to present according to the classic way. The x-rays here show gross destruction of the carpus. You can see the lunate sitting there. And now carefully feast your eyes on the metacarpophalangeal joints. You can see on the AP there seems to be a funny overshadowing. And it's when you get that oblique, you can clearly see the metacarpophalangeal joints have become pretty much dislocated, certainly severely subluxed. How might we treat with this? This is 6 weeks after surgery. And you can see that metacarpal heads look a little less prominent, and there's a cut here. And what have we done? We've done some joint replacements to help realign the extensor tendons. We've done a fusion, not the standard sort of plate, but in this case, so much destruction meant the normal fusion plates don't fit. And we've stabilized a rather wobbly metacarpophalangeal joint. So dropped fingers, extensor lag. This is your classic exam question. What causes extensor lag? The first one to think about is this Vaughan-Jackson lesion, attrition rupture due to caput ulni of the extensor tendons, classically occurring to the little, then the ring, then the middle, rarely the index finger, so they work across. In this case, clearly, if you grabbed a finger, you would be able to passively put it through at full extension. Next, extensor tendon subluxation. That will cause the finger to drop, but again, passively, the finger joint, the MCP, can be fully reduced with help passively. Metacarpophalangeal joint dislocation, you can imagine in that slide we just saw. If you ask the patient to extend the fingers, wouldn't be able to. But if you said, well, I'm just going to gently passively extend them, that dislocated metacarpophalangeal joint would mean that you couldn't, you didn't have the passive range. And classic posterior interosseous nerve palsy. There, of course, you'll see all the fingers affected. And that classically comes about with issues around the elbow, synovitis around the elbow causing post-interosseous nerve palsy. So those are the four you need to think about. Here's an example of somebody who's got those dropped fingers, and passively the joint couldn't be reduced. You can see the sort of that bulky look. You can imagine that x-ray showing subluxation of the joint. So the Swanson's joint replacement goes in. It helps realign the metacarpophalangeal joint. You can see you've lost the bulk, but also it's that extensor tendon realignment that occurs at the same time as surgery that's helping now keep those fingers extended. Let's have another look. Here you can see a relatively normal looking carpus and not so much of the radial deviation, but really terrible ulnar drift of the metacarpophalangeal joints. quick-witted will see there's just a few little anchors here. Somebody's had a bit of a go at trying to do some form of soft tissue reconstruction here. But here, it's these joint replacements again. And I've shown you a picture. These are the classic joint replacements that are used. And they go after the name of Al Swanson, an American who designed them. Of course, many companies now produce them, so they're not always called Swansons. They'll often be sometimes referred to as a silastic joint replacement. They're constrained. They suffer from fatigue fracture after some years. And think of them as a spacer. It's going to help with pain relief. It's going to help a little bit to realign the finger, but most significantly has a nice flat barrel upon which that extensor tendon can sit. And you can see here on the X-ray that ulnar drift has been corrected quite nicely. Here's an example of somebody attending as a new referral, and they're attempting to extend or open up both their hands. The left hand's working quite nicely, and this is as much as they can get that right hand open. And instantly you see that bulky look of the metacarpal phalangeal joints, and you know they're going to have dislocated joints. So passively, you won't be able to extend them. The chances are the extensor tendons are okay, sitting perhaps in the valleys. This is at 6 weeks post metacarpal phalangeal joint replacement of that right hand to show that realigning the tendons, giving them a mobile joint through replacement, can be quite significant. Of course, they still manifest that radial deviation through the carpus. You can see a boutonniere deformity of the little finger, but at least it's helped them gain that extension. Extensor tendon problems can, of course, be isolated. I've shown you some some hands that have been significantly affected through rheumatoid, but you might just see somebody with a rather earlier presentation, whereas they try and extend their fingers. They can't quite manage to extend one of them. Passively, the finger can be then pulled up, and you might just see that extensor tendon flick back into position. So extensor tendon subluxation can occur at a much earlier stage in an isolated digit, and there are a number of surgeries described to help stabilize that tendon and prevent it subluxing. Nodules can be quite unpleasant cosmetically. They can look awful. Patients want them removed. They also can be a little bit painful. Here's an example of somebody trying to flex and extend their finger to their maximum active extent. You can see the MCP joint's not moving at all. That's sublux, nice big nodule over it. Interestingly, look how good their proximal interphalangeal joints are, because of course the movement of the PIP joint is, in terms of extension, is through the intrinsics. It doesn't need that big extensor. After joint replacement, you can see that the joint's put into a much better position. Of course, still got the boutonniere deformity of the ring, but at least they're in a more extended posture now. We've opened up the hand a little bit. So how to deal with extensor tendon rupture? This is a little bit of a busy slide, but it's something that you need to think about. Possibly ignore the slide just for a second and stare at your own hand. What would you do if somebody presented with a dropped little finger? Well, you look at it, the other fingers are extending, so you've ruled out post-interosseous nerve palsy. You want to think about subluxation of the joint. Well, passively, the finger can be fully extended, so that seems less likely, although of course you're going to get an X-ray to check. So what are you going to do for that isolated finger? Well, you're going to, first of all, get rid of the cause of the extensor tendon rupture, which it could be a synovectomy, and dealing with that prominence of the ulnar head, which could be a Darix in a lower demand hand. You can piggyback the extensor tendons of the little finger to the ring finger. So a ring finger will support the little finger. But what are you going to do if two tendons are ruptured? Well, now you're going to use that good old extensor indicis, which is a really useful tendon to take with very little in the way of donor morbidity as a tendon transfer. And you're going to swing that extensor indicis tendon across to the extensor digiti minimi and DDC5, and you're going to piggyback the fourth to the third. But what are you going to do if there's three fingers out? Well, now it starts to become a little bit more tricky. You can take the extensor indicis and try and hang two fingers off it, the ring and the little, and piggyback the middle to the index, but you'll tend to have a little bit of a lagging. What happens if four fingers are gone? Well, that's it. It's all gone. You're going to have to do something else. You can take flexor digitorum superficialis of the ring finger and punch it through the interosseous membrane, or do a big bridge graft to the ruptured ends of the extensor tendons. So this is an example of a post-op tendon transfer. And here, it's had a synovectomy. Half the extensor retinaculum has been placed underneath the extensor tendons, half on top to keep that pulley going. And you can see here that there's some piggybacking going on of the little finger to the ring finger. Here, the extensor carpi ulnaris has been brought back up, a little sling manufactured. And these patients, this is one at 6 weeks, can do really quite well from these sorts of surgeries. This is an example of multiple ruptures. You can see a triumph of Ethibond. You can see all those ruptured ends distally. We just about have something off to the thumb there, but here a bridge graft has been placed for these multiple extensor tendon ruptures, and an extensor retinaculum has been created. This is the patient at around 6 weeks. You can see here, not so much in the way of active movement at the MCP joint, but almost more of a tenodesis effect. But at least the fingers are that little bit more extended, allowing the PIP joints to work their magic with a more open hand. So, on to fingers. Hang in there, everybody. It's the end of a long session, and these can often be things that are quite tricky that you need to go over a few times in your head. So here's a hand, and you can see the first thing is that somebody can present with boutonniere, a flexion deformity of the PIP joint, and swan neck, an extension or hyperextension deformity of the PIP joint in the same hand. So that's perfectly possible. Let's deal with swan necks. So swan necks, you have proximal interphalangeal joint hyperextension, and of course, by definition, the palmar plate's been affected. It's become lax, maybe through a synovitis within the joint. In the exam, you're just simply going to say there's an extensor tendon imbalance, sometimes related to the metacarpophalangeal joint or some intrinsic tightness, or it can happen after a chronic mallet finger. If the joint is flexible, you're going to ask your hand therapist to really help you out, and there are a number of different splints that can be used to help overcome that hyperextension of the PIP joint, which gives a nasty sort of snapping sensation as you try and overcome the extension. So these splints work by holding the finger and a little bit of flexion, so you don't have that painful overcoming of the hyperextension. And there are simple plastic ones, and there are some quite nice silver ones that some patients might invest in that look quite nice on the hand. Beyond that, the treatment depends on the joint condition. Get an X-ray. If it's degenerative, easy. The only thing you can offer them is a fusion. Between that, it gets rather tricky. No one hand surgeon really has a perfect answer to dealing with a swan neck deformity where it started to become a little fixed, but the joint is not showing any degenerative changes. You can do a little tenodesis effect to try and use a slip of FDS to hold the finger flexed. You can try intrinsic releases and mobilize the lateral bands, which will have started to migrate dorsally. Boutonniere, that's the other one. So here we've got flexion of the proximal interphalangeal joint, which very quickly becomes fixed. That palmar plate just loves to contract. Hyperextension of the distal interphalangeal joint and metacarpophalangeal joints. You can imagine that poor old central slip stretched with the lateral bands gradually migrating in a volar direction. A boutonniere, of course, with the bent finger, actually puts the finger in a bit more of a functional position. So you might just leave it well alone. There are some operations described to divide extensor tendon more distally to try and make the extensor mechanism retract and extend the PIP joint a little bit. And again, if, just like the swan neck, you've taken that X-ray, which you're always going to do, you've assessed the passive range of motion, but if it's degenerative, all you can really offer the patient is a fusion. Finally, onto the thumb. You'd be expected to sort of know that there's a number of different types of thumb deformity. And the Nalabuff classification is the classic one. But like any of these, just say, I believe there are a number of deformities. The most common is the boutonniere deformity of the thumb, and you can see here flexion of the MCP and hyperextension of the IP joint, and that's actually the type 1. Next, you might have the swan neck look to the thumb. That's easy. This is just mirroring the fingers, really. And you can see the first metacarpal is quite adducted. That poor old first cuff metacarpal joint struggling. A 4 is the gamekeeper's thumb. So actually, without realizing it, we've already done 1, 3, and 4. Gamekeeper's thumb just being a chronic attritional rupture of the ulnar collateral ligament. Here, the thumb's being stressed. So all we have to add in is a 2, which is a 1, with a cuff metacarpal joint dislocation, a 5, which is just a knackered hyperextended MCP joint in isolation, and a 6, which is arthritis mutilans showing bone loss. I think classifications are always really tough in the exam, but I think a simple way out of it is not to say there are 6, because then you'll be asked, well, what are the 6? I think it's always the classic answer to say, I understand there's a classification system called the Nellabuf with a number of different types, and start to then get stuck into it with the boutonniere, swan neck, the gamekeeper thumb, the destroyed bone, and that's going to give you a pretty good answer without sweating it too much, because in the heat of the moment, it's likely that if you really rehearsed it, you might just slip up. And that's me. That's the end of the rheumatoid hand presentation. Thank you.
Great, that was brilliant. Thank you, Mr. Chojnowski.
Thank you.
I think there's a couple of questions here.
So yeah, George, thank you, Mr. Chojnowski. Great talk. There are two, or now a few more questions coming up. The first one is with regards to rheumatoid hand, index finger MCPJ, is it better to replace or fuse?
The MCPJ?
Yeah. The index finger, yeah.
Yeah, so it is a great question. So the dogma of the index finger has always been, because you pinch onto the index finger, you know, can the index finger tolerate a joint replacement? It's really rather dogmatic. In the older books, they'd always be talking about fusions. Actually, we just replace, whether it's MCP or even PIP, we're replacing. And there's enough evidence beginning to creep out now that the joint replacements do okay. Obviously, you're going to desperately try and preserve those collateral ligaments which help, but you're going to keep that movement going at all costs. So the simple answer is replace.
Okay, thank you. And in the rheumatoid hand with deformities, what do you do for carpal tunnel syndrome and trigger fingers? Do you release them?
Yes, so you just manage them exactly as you would a non-rheumatoid hand. So there's not really any significant difference. You might try steroid injections first, carpal tunnel decompression if it hasn't worked, or they present in a more severe manner. And with a trigger finger, the classic dogma was that if you release the A1 pulleys on a rheumatoid hand, would you be accentuating their ulnar drift, allowing those flexor tendons to kind of drift a little bit more ulnar? But the bottom line is you're going to deal with the triggering first. And actually, yes, you're just going to perform trigger releases. So you deal with them in the way that you would a non-rheumatoid hand.
Thank you very much. I think that's all the questions we have for now. I'll leave it to George.
Great. Yeah, there was one other question in the first book, which actually Mr. Logan's answered, but it was a best source for hands revision for FRCS. And Mr. Logan said that Sanjeev Agarwal has written an FRCS revision book, which is designed to cover what you need to know without going too far. So I think that answers that question nicely, just for everyone. I don't know if Mr. Chojnowski or Mr. Lamb have any additional resources that they'd recommend.
No, I think actually Greens has a nice few little bits on the rheumatoid hand, which you can flick through if you find a Greens hanging around. Just a couple of other bits, some questions that have popped up. Does the Z-shaped thumb, it depends which way you base the Z, it's either a boutonniere or a swan neck. And the Fowlers, no, you don't actually reattach the central slit per se. You just simply divide it distally and allow the whole extensor mechanism to retract.
Great. Thank you so much for your time, everyone. Sorry we ran a little bit over, and thank you for sticking with us. If you could remember to please fill out your feedback forms you'll get at the end of this session and in an email. Just one other quick announcement that our new BOTA website will be launching this coming week, so keep an eye on social media for launch. All of these sessions will be recorded and hosted via YouTube, and links will be on the website so you can watch it back and take some notes. And I know I certainly will be when my exam comes around. So thank you so much, everyone.
That's great.